particularly brain fog. We are going to be recording this question and answer and this whole webinar, so please be aware of that. I'll give you a brief introduction to Dr. McIntyre. He will take the floor. We'll ask him a few questions, and then at the end, we'll join in and we'll have a question and answer period. Feel free to use the chat function where you can leave your questions, and they will be directed towards Dr. McIntyre. So I think a good place to start is let's talk about long COVID and what's going on with the new research and statistics that just came out yesterday with the prevalence of long COVID. And Dr. McIntyre, what do you think of that? What do you think of the accuracy of this report? And how do you think this is going to affect Dr. McIntyre? Hang on a second, everyone.
Okay, thank you. I've just been unmuted. That's why I was trying to get unmuted there.
Okay.
This is the famous unmute button of the pandemic. You know, it's a good, Susie, it's good to be with you again, and nice to be having this opportunity to chat with you about this topic, this very serious, very common, very debilitating new syndrome. And yesterday, it came across my desk, the press release from Statistics Canada. I'd urge everyone to have a look at it. And to be quite frank, I wasn't surprised. I mentioned your own reaction, Susie, as well. I wasn't surprised. For those who maybe haven't had a chance to have a look at the document that was released yesterday, this was a survey by Statistics Canada, of course, part of the Government of Canada, an arm of the government. And they had concluded, and this is a very, very, top line summary, that about a third of Canadians had tested positive by test for COVID. A third, about 10 to 15% or so more did not test positive, but were pretty convinced that they had it. So I think we're at a stage now, I think, where there is a consensus that whatever the rate is of infection, it's high, and it's probably a lot higher than the tested positive rate was. So a lot of people have been infected. But what caught my eye, Susie, was the overall percentage of people who were experiencing more persistent symptoms. And I've noticed that Statistics Canada doesn't use as readily the language of long COVID or post-COVID or post-acute sequelae COVID. But they describe these ongoing symptoms, 15 to 20% or so of people. So that's an estimate which is not too far away. It's kind of within the range of what we see from many other studies, some lower, some higher, of people having this syndrome. And what also caught my eye, Susie, is the type of symptoms that Canadians were experiencing, very much aligned with other published literature and our own experience, that people are experiencing fatigue, and not just like everyday fatigue, but fatigue that they've never had before. This is just like paralyzing fatigue. Second was some of the respiratory symptoms, shortness of breath, things like that, some coughing, things like that. And then thirdly was the brain fog came out as really, a problem. And this has been a very debilitating condition. What's interesting, Susie, is that in the United States, the Brookings Institute, which is a very well-known institute in the United States, recently estimated that on the low end, 2 million, on the higher end, 4 million Americans are not able to work because of long COVID. So it's one thing to have symptoms. It's one thing to affect a lot of people. It's another thing when it begins to be debilitating. And not being able to get to work, that's debilitating by anyone's definition. And then it has a vicious cycle to it, because if you ain't getting to work, chances are you're not able to get your paycheck. And not getting your paycheck means a little difficult to buy groceries, and so on and so on. And so you're in a really vicious cycle there. So that's not good news. So I thought the survey was very much not surprising. I thought the estimated rates were on the lower end. Susie, what were your thoughts? I think do you have to unmute, Susie? Not sure how this works, guys.
There we are. Yeah, I was trying to unmute myself there. Yeah, I would agree with everything you said there. With the numbers not including people with an assumed COVID diagnosis without a PCR test, then we could maybe assume that the numbers would be higher. Interestingly so, that at least we're getting some acknowledgement, which is great. And thank you very much for, continuing your friendship with us and being there for us and always coming to speak with us. So I guess was wondering with that in mind, if there's been any more forward development on what a definition of what long COVID is.
Yeah, and that's a really good point. And what happened in the last almost 3 years now, if you can believe it, that's quite interesting in of itself, is here's this new condition. 3 years is considered very new in medicine, and a very new condition that has presented itself. And I would start off by saying it's still a work in progress with respect to the definition and the criteria. For now, we have different groups. We have the US government, one of the arms of the British US government, they have a definition. There's a group in the UK has a definition, of course, the World Health Organization's definition. But I think specifics aside for a moment, and that can, that can be debated and discussed, there is a consensus. It's a package, if you will, a packet of symptoms. And these are symptoms that are persisting and they occur within some time frame of the infection, usually 3 months, and they persist for at least a couple months. I think what's really interesting now for me on this one, Susie, is that we're beginning to see rates of remission. In other words, how many people, what percentage of people are fully recovered, say within 6 months or 9 months or 12 months, because just simply we're living long, this is going on and on and on. So now we're having a longer runway to look at this. And I had hoped, I'm sure what you had hoped, that after a year or even 18 months, all the symptoms go away for everybody. And we all hope that, but that's not happening. So I'm quite struck at the persistence, but I'm quite struck by, Susie, I'm quite struck by the persistence of some symptoms. Respiratory symptoms are common, like breathing problems, but they don't persist in most people most of the time. But what's persisting is this terrible, terrible fatigue and the brain fog. And I'm not surprised by that, because when you look back at other pandemics, I've had an interest in this as a scientist for a long time, looking way back. Of course, nobody knew anything about the Spanish flu until this pandemic happened, and we all know the Spanish flu. But there's been many other epidemics, pandemics, and so on over the years. And this is very common. It's very common to see this. What's interesting? Back in the 1920s, when the Spanish flu happened, and of course, this was an influenza virus, and it affected so many people, largely in the United States, and it did not originate in Spain. That's a whole other story, but that's for another day. It turned out for the next 1, 2, 3 years, medical clinics across America were being flooded with people who just couldn't get out of bed. They were so tired. They had a condition called lethargica. Lethargica meaning lethargy, just tired, fatigued. They had no zip. And people were like, what is going on here? What's happening here? So there seems to be something about some viruses. Once you were, in quotes, recover from the acute infection, you're left with this scenario where you are fatigued. And what's interesting is that we have in the neuroscience community begun to really unravel what is it that's causing fatigue. I'll say more about that in a few moments. Before I do, I want to also just say that there's also a different body of scientific research going on. And this body of scientific work has really revealed some interesting aspects about long COVID. One of which is, one theory has been, and there's a bit of data now to support this, that many people who have long COVID have ongoing virus in their body, and the virus is still there, and the immune system is still reacting to it. That's one theory that's been out there, some data to support that. I think what most people know is that long COVID is associated with some type of super activation of the immune system. And we call it collateral damage or friendly fire, where the immune system kills the virus, or at least attenuates it, but it certainly, in fact, can cause additional problems on even friendly tissue, your own body. Thirdly, there's this theory around clotting that maybe what's happening is that because of the immune reaction, the blood gets sticky. And for those who are maybe a little less familiar, your blood can get sticky or less sticky. We give people aspirin to make their blood less sticky, but the blood can get really sticky when you're in a situation of immune activation. And a lot of people think little clots maybe causing this little in your brain, making you fatigued and things like that. So there's a number of theories. Those aren't the only ones, but those are the ones that are getting a lot of attention these days. Ongoing virus, the immune system's activated, these clots in your brain. But the other part about this, Susie, is that we're really starting to see a pattern. It seems as though women are more at risk of this. At least that's what the data seem to suggest. And the other part is, it seems as though the earlier variants were a little more likely to cause long COVID than the more recent variant, although the recent variant causes it too. So it doesn't cause it, but there's some suggestion of that now. I had suspected, I had hoped that people who had vaccines, either after getting COVID or had the vaccine, they got breakthrough COVID. I had hoped at this stage we'd be in a position to say that the vaccine took care of the long COVID. That is also not the case. It's escaping the immune system. It's escaping that. So we need to find some type of solution. But here's the part. Before we begin to think about a solution, we have to think about what's causing this fatigue and what's causing all this brain fog, because that's what's the two most persisting and debilitating symptoms. And we've done a lot of work in this area, and we've been able to find areas of the brain that are responsible for motivation, your sort of energy, your get up and go, as well as the clarity of your thought processes. And people are having this foggy brain, and their cognitive functions, that their brain functions are reduced. Their Pentium chip, so to speak, is not as processing as quickly as it could. And we've been able to figure out the parts of the brain that is related to. So when we set off on this journey, when we have a new disease or a disease that's not new, a disease we know, there's sort of a kind of a general rule in medicine. And the rule in medicine is you should try to find out what the cause of the problem is. And then once you find out the cause, then that might inform the treatment. It makes good sense. That's not very complicated. And our view then, when we started our study, our view now is we don't disagree with that. But people are suffering now. And until we figure out what's causing this, we need treatments. That's no different than many other medical conditions. Arthritis, lupus, depression. There's so many conditions, we don't know what really is causing them. We have ideas, but we don't really have it fully unraveled, but we've got to treat people. And long COVID has to be treated. So, and we don't think that we happen to believe you can walk and chew gum at the same time, that you can actually treat a condition and indirectly begin to look at what's causing it. So many of the folks joining us tonight may be a little less familiar with the study. So maybe I'll just give a brief description of the study, the treatment, where we're at, and how people can really determine whether they're eligible. By the way, Susie, in addition to your mugshot, my mugshot on the screen, we have the email address that people can reach out to the team and inquire as to whether or not you may be eligible for enrollment in the study. So just I'll give you people a moment to take a little picture of that, what have you. I should also mention this program is audio recorded, so we're going to be maybe posting it as well. But anyhow, we were sitting one day and we were sort of thinking to ourselves, here's this problem with fatigue and brain fog and interest. And we think that something about this is due to the immune system. And what our logic was is that let's figure out what's causing this, absolutely. But in the interim, why can't we do both? Because we already have treatments that can both affect the immune system. And people, by the way, Susie, would love to have the energy your cat has. So I think that your cat's wonderful, and that's the goal of to have that level of energy would be amazing. So anyways, can we have a treatment that is able to give people their clarity of thinking back, nice and sharp thinking, and also a treatment that could help the fatigue and affect the immune system? So we went through our chest, if you will, of different medications, and we pulled out a medication that did all three. It helped the immune system, it boosted it, it helped fatigue big time, and it also helped brain fog. And we
Can I just jump in here for 1 second and ask you, does it also have effect on mood?
100%. And I'm so glad you asked, because the area of the brain that is related to the brain fog and the area of the brain that's related to the fatigue is in the same zip code, it's in the same area as the area responsible for your mood. And people have often asked me, Susie, all over the world, say, hey, Roger, do you think this is a psychiatric problem? I say, it's not really a psychiatric problem. It's not really any type of problem. It affects different organs of the body. It affects the brain. And it affects any organ in the body, including the brain. And so when the immune system in the brain begins to target, it begins to target this area. And that's why people are also finding their mood is down. You know what's interesting, Susie? We've been looking at what are some of the risk factors. Remember I said women are seeing it more often? The other group that's seeing it more often is people who have a prior history of depression. So there's some literature on that. That doesn't mean, I'm not suggesting that this is a mood disorder. What I'm just saying is clearly people who have a history of depression, maybe their immune system is a bit more susceptible, and maybe their brain area is a bit more susceptible to the immune system, if you see what I mean, and maybe they're just more vulnerable. And the other part about that, which I think is worth mentioning, is that people who have obesity or diabetes might be at higher risk too. And that all fits together, because if you have diabetes or obesity, that's also activating your immune system and can affect the same area of your brain. And people who have obesity and diabetes, they have a lot of problems with their brain not being as sharp as they like it to be and being very tired. So it's all the same thing. And so the medication, we decided to go with a medication called vortioxetine. And that's a medication that would be nothing to anybody, but it's a medication in Canada, all around the world, over 50, 60 countries. It's actually approved as an antidepressant, just coincidentally. But the names that we give medications in psychiatry especially don't really give, I guess, justice to what they actually do. Yes, it's an antidepressant. If you're depressed, this could help you, of course. But we use a lot of medications in medicine for different reasons. I mean, aspirin's always the example, can help pain, can help thin your blood, help your, it can help your headaches. We use it to protect your heart. We do all kinds of things with aspirin. So drugs have different purposes. And when you put the drug in your body doesn't know what the medical indication is. It just reacts to the drug, and the drug can target different molecules and systems in your body. And it turns out that vortioxetine, which is an antidepressant, also appears to be one of the best drugs for brain fog we have and fatigue in the immune system. So we thought this is intuitive. And in the United States, the United States Food and Drug Administration, the FDA, already approved this drug for people who have mood disorders, but more particularly for help their cognition. So we thought this is kind of a no-brainer. Let's just go with this one. So we said, okay, let's do the study, and we're going to try to help people now. People want help now. And we want to try and do a study, find out a solution now. And we're going to do a bunch of measures, bunch of tests to see if, in fact, we can make matters better for people now, but also get some leads on what might be causing this by taking some blood work and so on. So people would come into the study. It's 8 weeks in duration. And you're going to come into the study. You're going to get one of two treatments. You're going to get a placebo, and you're going to get or the medication vortioxetine for 8 weeks. And the reason why we do with a placebo is because if people begin to get better, we won't know if it's because the medication itself only is doing it, or are there other factors at play? We have a great staff, great team, people feel good seeing them, stuff like that. And so we need to have a placebo arm. Placebo works very, very well, but the medication works better. And that's why we need to have both. And at the end of the study, we're looking at the change in a person's their cognitive abilities, how fast their mind can think, like their Pentium chip. We're checking other things too, like their memory and so on. And we're also checking their fatigue and their overall function, their quality of life, their well-being, trying to get people feeling better. So we're aiming to recruit, Susie, 200 people. You may have heard me mention that before. If anyone is on the call tonight joining us, thinks it might be interested and possibly eligible, don't hesitate to call, because we're really getting into the final days now of recruitment. It's going to close in the not too distant future. There's been so many inquiries. We've had hundreds and hundreds and hundreds of people have been inquiring, and hundreds, in fact, are in the study now. So, but we're going to have to close it pretty soon because it's been such a robust response. And I'm hoping that we'll be able to have results, Susie, by, well, January, latest February. And I'm hoping we're going to have the first solution ever to help people with long COVID. Now, let's stop there.
Do you know how many people are enrolled in the study as it is right now?
Yeah, so right now we got close to 175 people in the study now already. Yeah.
That's fantastic. So people better get in there quick if they want to take part in this, right?
100%, 100%. So, and I wouldn't, it's always heartbreaking when someone wants to get in and they can't get in. So I think they got to really call up the staff as soon as possible, and folks will see them, and we'll bring them in if eligible, of course.
Someone asked here in the chat if there's also I think what they're asking is if there's a for people with diagnosed with PTSD, would they be more likely to get long COVID?
Oh, what a great question. And the answer is we don't know. How's that for certainty? We don't know. But I love the question because as a scientist, I am aware that depression is one of the risk factors. You don't need to have depression, but it's a risk factor for long COVID. I am not convinced that will be the only mental illness or the only psychiatric illness that's linked to COVID. I think post-traumatic stress is an excellent question. I've not seen data yet on that one in particular, but we've wondered if there's some data about past history of trauma. Maybe people don't. A lot of people have trauma in their history, but they don't have PTSD. And so there's two different parts to that. The PTSD and a history of trauma. Of course, they usually go together, but not always. So it's a great question. Don't know, but trauma does disrupt the immune system. So it's a very good question, and that's one that's looking. I should mention that if someone had PTSD, they would not necessarily be ineligible. In other words, they may be eligible for a study. The team will go through a questionnaire with you and so on and so on. And people often ask, well, what if I have this medical problem or that medical problem? Can I get in? And the answer is maybe. Just give the team a call. And so we appreciate that, life goes on and life's got bumps and bruises. We got medical problems before COVID and or even coincident with COVID. And so, yeah, absolutely. Just talk to the team. And we have a checklist, pretty simple, very easy screening just to see if you have the checklist. If you do, then you're in. If not, then we won't be able to bring you in. But it's very easy to sort that out. Don't hesitate. A lot of people, Susie, will say, well, I'm on this medication and that medication, this medication, that medication. Yeah, most people are. And you might be eligible to come in the study. And the team, again, we have a bit of a list of things you can't be on, but I don't want to get into all the details right now. But just talking to the staff, they can kind of go through that real quick to determine whether or not there's any kind of deal breaker medications. But we've got a lot of medications that we allow in the study.
Great. Okay, people, you can ask your questions now. Do you know if duloxetine is similar to vortioxetine? It's
quite different. It's a bit like brothers and sisters. There's some similarities, but I would argue that there's a lot of differences too. So they're similar insofar as they're both considered antidepressants, but beyond that, they're not much similar. And they're very, very different. So duloxetine has not been subject to study as a treatment for long COVID. And frankly, it would not be a drug that we would study for long COVID because it hasn't demonstrated the effect on brain fog or fatigue to the extent 40-oxytene has. And it also hasn't demonstrated its effect on the immune system the way 40-oxytene does. So when I went into this, I thought to myself, whatever candidate we're going to go with, it has to have 3 check marks. It has to be able to help brain fog, help fatigue, and help the immune system. And so with those 3 check marks as being the non-negotiable, we end up with 40-oxygen.
Okay, we're getting a lot of questions here now. First of all, let's go to the one about Quebec. And are people able to take place in this study if they live in Quebec or outside of Ontario?
Oh, what a great question. Anyone across the country would be eligible to be in the study in Canada. Now, we have a clinic in downtown Toronto, right in the heart of Bay and Bloor, right downtown. And we prefer to see people in person, but we recognize that's not possible for this reason or that reason. And we've got people from all across the country who've been participants. And there's ways that we can see people virtually and also ship medications, things like that. And so there's ways things can be worked out. So that's a great question. The study is open to everyone right across the country. And don't be shy. You could be eligible. We get a lot of questions, by the way, I spend a lot of my time down in the US, our US friends. Unfortunately, we can't bring some of our US colleagues in right now into the study. We have, because the way the study's been approved by the government and by the authorities and the ethics boards and all that, we have it only for the Canadian folk. But look, from yesterday's survey from StatsCan, we got a lot of Canadians suffering. So I think we got to start with that.
Okay, there's a question about eyes, and I wanted to say in particular, I was having a lot of trouble, little difficulties in reading because of the brain fog, and my brain really felt like it had a brain injury. And when I did some occupational therapy, the therapist noticed that my eyes weren't tracking properly. Do you know how COVID is affecting the eyes in different ways?
Yeah, what a great question. We're seeing lots of reports of that with respect to not just visual change, but also the degree wherein there's coordination of eyes moving, you know, your eyes obviously have to be in sync, etc. We're hearing a lot of these reports clearly. And what's interesting is that the eyes are increasingly becoming a focus of perhaps even diagnosing certain psychiatric problems. For example, Alzheimer's disease, which is a psychiatric neurologic problem. That diagnosis is still made by seeing an expert, a clinician who makes the diagnosis clinically. But there's some really interesting data now to show that you might be able to diagnose Alzheimer's disease by looking at someone's eye. People are doing this research right now because the eye, you know, they say it's the window to the soul, all that kind of stuff, but the eye is actually the window to the brain. In the back of your eye, that's directly communicating to your brain. And so it just stands to reason if your brain is under assault by long COVID, then the eye is going to be affected. And we are seeing reports of that, absolutely.
Thank you, that's great. Are people eligible to join the study without a positive PCR test?
That is a great question. And the answer is yes. And we recognize, in the StatsCan survey commented on this yesterday, that for many Canadians, they didn't have the ability to get, I mean, remember when testing was in short supply there for a while, and you know, people couldn't get a test for many people told me they couldn't even get a test. And so we want to make this as equitable as possible. We don't want anyone to be not having access to the study because they couldn't get a test. That wouldn't be fair. And the other part is that, you know, we want to make sure this is very inclusive. That being said, is that obviously we want to, if we can, we prefer a test because guess what? There's other bugs out there. And if you got a really bad illness, yeah, good chance it's COVID, we all agree, but it could have been something else. It could have been the flu, whatever the case may be. So what we do in that case, Susie, the short answer is yes, you could still possibly be eligible without the positive test. But what we do is we have a set of questions we're going to go through with you, talk to the team. There's the email address, and reach out and we can go through. We get this question all the time, almost every day. So we've got a set of questions we'll go through with you that'll make it much more, I guess, confident that it is COVID that you had, even though you didn't have a test.
Thank you.
Yeah.
Is vortioxetine an SSRI, and would any SSRI work?
Great question. No, vortioxetine is not an SSRI. Vortioxetine is an antidepressant. SSRIs are antidepressants. An apple and an orange are fruit, but they're totally different. And so they're the same category, but they're totally different. And vortioxetine is called a multimodal. What does that even mean? Multimodal antidepressant. It's a different ball game than an SSRI, and the government recognizes that in the sense that they label it differently. It has a different name, how it's categorized, and the science behind it is also very different. And a comment I made earlier, I'll just repeat that the FDA of the United States, the only antidepressant that the United States Food and Drug Administration, the most rigorous group anywhere, what they actually decided was the only antidepressant that has beneficial effects on cognition is vortioxetine. So there's a difference from duloxetine, Cymbalta, or SSRIs. And that's why we went with it, in part.
Sorry about that.
Yeah.
How informed are doctors of long COVID, do you think?
I think the word's out. I think the word is out. I talk to a lot of doctors and nurses across this country, the United States, all around the world on a weekly basis. And the word is out. They know about it. I think in some fairness to the healthcare community, and like everybody else, I think it's still a kind of a moving thing. We're trying to understand it more. And there's probably less we know than we'd like to at this stage still. I am hearing from a lot of people that their doctor doesn't know what it is, or is dismissive, or is maybe even skeptical. I hear this from people, etc. And I'd react by saying, first of all, that's unfortunate. Second is that that people should find a care provider that they feel comfortable with, that will give them a comprehensive assessment. But I think it's generally well known. And the reason why I think that, Susie, is because I'm quite involved with education of doctors and nurses, and it's in a lot of teaching. It's getting out there, words out there. But I would say this is that doctors and nurses are not doctors and nurses first and foremost. They're human beings. They're doctors and nurses because society has a construction called university that they get a degree and become a nurse or a doctor. They're human beings. And what we as human beings, doesn't matter who you are less comfortable with is things that we don't know what's going on. And doctors are no different, nurses are no different. I can say I'm a doctor. And we as doctors are less comfortable when we don't know, A, what's going on, and B, how to treat this. And people get frustrated because they're human beings. And I think that's part of it as well. That enters into the equation. That's just understandable human reaction. Now, I don't think people should be skeptical. You should be open-minded. I'm not saying that. I'm just saying that I know I'm getting all kinds of feedback from people over the last couple of years. All kinds of things come back to me. And I get it. But I guess you could, perhaps because I'm a psychiatrist, I've been in psychiatry, I've been in this for a long, long time, and I see a lot of things. I understand a lot of people still to this day don't even believe depression exists. So, I mean, I think that's crazy. But so I understand where this is coming from, and that doesn't make people feel good when they're being dismissed. But I think generally speaking, the word's getting out. I think why we're doing the study is we want to give people a solution. No one wants to go to their doctor and the doctor says, oh, you got a problem. Next patient, no one wants that. Can you imagine? Go to the doctor, you have a problem. First, your response is, oh, thank you. What's the solution? And they say, I don't have one. So no, we want a solution. So that's why we're doing the study, to get a solution. Canadians deserve it. And, you know, I can say this as an academic. Academics take their time on everything. People need solutions now. And they're obliged to give solutions now. That's why we're doing it this way.
Great answer. Thank you. Are there any statistics on how long COVID persists, and what are the percentage of long haulers that have fully recovered?
Yeah, so there are, and it begins with, it's a bit complicated, but let's make it digestible. First is that a significant percentage of people continue to have symptoms 6 to 12 months later. A very significant. What is the percentage? Depends how it's defined, and et cetera, et cetera. I think what we can say, Susie, is that for some very fortunate souls, this condition gets better for some people over 6 to 12 months. That is very clearly documented in the literature. And let's hope that percentage gets higher and higher. But there's clearly a percentage. What is it? 10%, up to 30%, some studies, gets better, somewhere in that range over 6 to 12 months. But remember I said that brain fog and fatigue are the most persisting? And here's where I'm going with this thought, is that yes, you may not have the full long COVID a year out, although you may not have a long list of symptoms. But all you need is one symptom to cause a lot of ruin to your quality of life and function. I wouldn't want to be brain fogged all day long, and that one symptom could rain on my parade. I wouldn't want to be fatigued all day long. Who does? So I don't think I think having just 1 or 2 symptoms is enough to be debilitating. And if we look at it through that lens, which I think is a very appropriate lens, because that's what affects people's lives, it's the majority of people are still having a lot of problems 6 to 12 months out. And so I think this is turning out to be persistent. It's common, it's persistent, and it's very debilitating. And you don't need a lot of the symptoms to really rain on your parade to make life miserable for you, because 1 or 2 symptoms can do it. And my experience has been as a psychiatrist is that of all the symptoms that can affect the brain, the 2 that really cause the most problems is fatigue and brain fog, no question. And so I'm not surprised people are still suffering. And so it's going on a lot longer. I remember when we first met, Susie, you and I were talking about long COVID way back in the early days of this. I had really thought that there'd be a lot more people fully recovering than actually have. This is going on a lot more. And I'm glad that the Canadian government is really prioritizing this and doing those surveys. I was really pleased to see that. I really was.
Okay, here's a question about the medication, vortioxetine. What is the percentage of subjects that have had an adverse effect from vortioxetine?
Yeah, that's a good question. So everything has side effects. Placebo has side effects. Everything has side effects. And side effects come in 3 sizes, Susie: small, medium, and large. And the second point is side effects can sometimes be just a nuisance, and some side effects can be such a problem you have to stop the medication. So the side effects of vortioxetine have been well documented. The medication's been around for a decade. It's not a new kid on the block. It's been used in over 65 countries, and it's used widely. So we have a large experience with it. First is there's no serious safety concerns that we know about, no weird reactions people get on this drug, things like that. Second is that most of the side effects tend to be the small side effects, not the medium or large one. No, they're nuisance, maybe a bit of dizziness, upset your stomach for a bit, for maybe a week or 2, then it goes away. And the percentage of people who have side effects that are so unpleasant and nasty that it reduces their ability to stay on the medication is very low. Now, we haven't finished our study yet, but for this medication, you ready for this, Susie? It's between 1% and 3% max. That's it. So I was walking home tonight. I saw the Lotto Max, $70 million. I don't buy lottery tickets. But if you had a 99% chance of winning that lottery, I think you'd buy it. So it's a 99% chance you're not going to get side effects enough to cause you to drop out.
Well, that's
It's very well tolerated. And people don't want side effects. But I would say this, Susie, there are side effects to COVID. It's called long COVID.
Mhm.
And I wouldn't want that side effect, and you're already getting it. So let's get rid of that side effect with a medication that we think to be very safe and well tolerated.
I think we should try. Okay, here's a question about ME/CFS. So what is the difference between post-viral ME/CFS and long COVID?
Great question. I would say to be determined. So for that's a lot of acronyms there. I think that's the myalgic encephalitis chronic fatigue syndrome.
Mhm.
And that's a different bug. It's linked to Epstein-Barr and on. But so I won't say that that's the same thing as long COVID. But what I would say is the following. If you're walking through your living room and you bump your leg against the coffee table, it gets all black and blue. If you are getting out of your car and stumble on the ground and hit your knee gets black and blue. Two different events cause your leg to go black and blue, but they're two different events. And so the myalgic encephalitis chronic fatigue syndrome, still is a mystery, a lot of insights, is caused by a different virus, or at least that's classically described as a virus, but there's a lot of symptoms that are in common with long COVID. The fatigue, persistent debility from the fatigue, cognitive problems, and so on. So again, what happens is that the body has a relatively small number of ways where it can tell you that it's suffering. And fatigue and brain fog are two of the most common. That's why just about everybody's experienced that at least one time in their life. The common cold, what are the most common symptoms? Tired, brain fog, lose your appetite. That's just a common experience when you get a bug in you. And chronic fatigue syndrome has a lot of symptoms overlapping with long COVID. There is a different virus that's linked to that. I can't say they're the same thing. We don't know that, but there are some overlaps using my bumping the leg metaphor.
And so many different symptoms, and we just say long COVID, ME/CFS is long COVID and more. Long COVID is more. It's so many different symptoms and clusters of symptoms. So do you think that long COVID is going to have a big impact, a large impact on our healthcare system?
Yes, and we're already seeing that. And we're seeing that in some American data. There may be some Canadian data, so I'll have to apologize. I'm not sure if I know if we've seen this. You might know that, Susie. Have we seen some service utilization data here in Canada? I mean, the answer is it's going to happen. We're already seeing it. But whether it's been documented, I don't know that. I know the US data. And yes, we're already seeing that you see an increase in utility of healthcare services, and we're seeing an increase in disability at work, which means people have to get a disability payment. That's obviously costing the situation and all of that. And that's interfering with their economics, their income. So the answer is yes, it is the case. And what's interesting is that long COVID, because it affects so many organ systems, your lungs, your heart, your eyes, your brain, your liver, your this, your that. People with long COVID are going to their family doctor, they're going to the dermatologist, they're going to the rheumatologist, the psychiatrist, the neurologist. So not only is long COVID increasing service utilization, but people are utilizing services across many different specialties because there's so many ways this can present. That's why it's really important for us in the medical establishment to compare notes, because people could stand to benefit by us putting all of our notes together. And it is the case that many people we see in our study, they have long COVID. They got other symptoms going on as well. So maybe we can all learn from each other. So it's not only a high level of service utilization, but I would say that unlike many other medical problems, it's like people are using all kinds of services. No one really knows what is going on, and everyone's different. Some people have other symptoms that bother them more than other symptoms, and that might influence what type of specialists they see and so on. So the answer is yes.
Okay. So this question is from someone who's wondering about what level are doctors able to provide a diagnosis of long COVID versus something, a different condition such as burnout. She was diagnosed with burnout, but she's still struggling with separate symptoms after this. So
yeah, I appreciate that question, and sorry to hear about what's going on with you. That's unfortunate. So sorry to hear that. Good question. Any family physician, and frankly, there's a lot of great, nurses, nurse practitioners, but any physician, a family physician, certainly they're very skilled. They can diagnose long COVID. You don't need to see a specialist, I guess is what I'm saying. A primary care provider, they're excellent to make the diagnosis for sure. I would say, going back to a point I made earlier, Susie, I think that any specialist could make this diagnosis because I think almost any specialist is seeing it. And so now, not like everything else in life. Doctors have their areas of comfort and areas where they're not as comfortable, and et cetera. So not all doctors would be as comfortable because it's just not something maybe they see a lot or what have you, or and all that. But generally speaking, this is a diagnosis which is well known to the primary care community and the specialty care community. And from the point of view of ability to make that diagnosis, there is no question that they can all make that diagnosis. There's not one, like, you don't need to see a rheumatologist or a neurologist. You don't need to see a psychiatrist. I think a family doctor will be fine.
Great. Okay, this one's a long one. How is the mechanism of brain fog influenced by post-exertional symptom exacerbation? A lot of people find that the exertion makes brain fog far worse. So if brain fog is in large part connected with the immune system's inflammatory effects on the brain, how does exertion affect that process?
Wow, wonderful question. I would conclude by saying the following, Susan. I think that what we can say is that there may be some overlap. It may be overly simplistic. I don't know if that's the whole story, but there may be some overlap insofar as one of the aspects about exercise. Now, first of all, Susie, let me make the message clear. Exercise is good for you. It's healthy. But when you just begin to start exercising, in the early moments of exercising, it actually activates your immune system. Now, just so I'm clear, exercise is good for you and healthy. All right. But what happens is because let's say you go to the gym and you start on the treadmill, that first 5 to 10 minutes is awful because your body's getting a stress, and that stress activates the immune system. Now, if you keep working out, the stress goes down and then the immune goes down. In fact, it gets really down. It's that because exercise is anti-inflammatory actually in the long term. But in those few moments, it's actually a stress to your body. And that releases immune proteins, which could make some of this worse in the short term. That's been one theory that's been thrown around. The other part is that some people think the reason why people get long COVID, I talked about a few theories, I didn't go through them all, is that they don't get enough oxygen to their brain. Maybe because the lungs are not quite right after COVID, this kind of thing, what have you. And if you're huffing and puffing and you're trying to breathe and you're short of breath, you might not be getting enough oxygen. I'm not saying you're so low you have to go to the hospital, your oxygen, but your efficiency of how you're using the oxygen is not as good as it could be. Some people think that's going on. So there is some overlap, but the exertional fatigue, which is so profound, getting up the couch to go to the fridge to get a soda, and you're tired. My gosh, that is likely something to do with the immune system affecting the efficiency of your energy. And that likely has some overlap with what's going on in the brain, but it's not that simple. But there are some overlaps.
As well as post-concussive symptoms.
Yes, I mean, that's interesting. Post-concussion syndromes, of course, you can hit your head many different ways. And I've seen hundreds, probably thousands of people who've had post-concussion syndromes in my career, certainly thousands, I guess it would be. And they almost always have brain fog, and they almost always have fatigue. And that is in part because the injury to the brain is what's leading to that. And it's obvious what the cause is, you hit your head. But the other part is that if you have an activated immune system, it also can do damage to the brain. And we think what's happening is the activated immune system, because of COVID, because of the legacy of COVID, is causing injuries to the brain cells. And those injuries to the brain cells are what's manifesting as this fatigue and brain fog. So exactly that.
So can vortioxetine help with any language issues that are arising from long COVID? Like, what part of the brain is our language word recall in? And can vortioxetine help with this symptom?
Great question. You know, word finding difficulties are some of the most common complaints people have. And just so we're all on the same page, so, you know, you're making reference to a pen. You can't remember what's that? It's a pen. It's a pen. I can't remember the word is. So the words don't come down automatically. And that's a problem. Just imagine your computer, you're trying to retrieve a file in your documents, your Word files. We do the same thing. We're trying to retrieve documents in our brain, and naming something's a document. And what's happening is the retrieval process is abnormal, just like trying to retrieve something from your Microsoft Windows. And very common. And it's a problem with the memory system, largely, other parts as well. And for brain fog, you know, your mind slows down, it's fuzzy, not very efficient. But there's also memory problems as well. And that's a problem with the memory system, trying to retrieve the name. And this medication, vortioxetine, has been shown to improve the speed of the processor in your brain, makes you more, you know, back to normal. But it also helps the word finding difficulties as well. So it's a really nice detailed question. So yes, it does help word finding.
So this might, as you said, it helps the speed, processing speed, which might aid, and people are finding it difficult to drive and difficult to make decision making. And I struggle with word recall a lot, and I don't know, you can tell with this webinar, I'm really tired, and to find the words, it's very, very difficult. So
one of the most common complaints I've heard about COVID, people don't talk about, is word finding.
That's great. Okay, well,
oh, I think you're muted there, Susie.
thank you. It's almost 7 o'clock, so I think we'll wrap up. A lot of great questions. You can ask your questions directly if you're involved in this study. And to get involved, we have posted this in our group, in all the provincial groups, as well as the main national group. It is in the it's highlighted at the top of the group, the bulletin board area. I can't think of the name of that right now, but so please do get involved. As Dr. McIntyre said, there aren't too many spots left. Let's try and fill this up as quickly as we can so that the study can be concluded. We can all get the wonderful, looking forward to finding out the results and sharing that. And I hope, Dr. McIntyre, that you will come back again to our group and share some more of your precious time with us.
I'd be happy to. Thanks for all you do, Susie. So wonderful for all the Canadians benefiting from your passion. And thanks everyone for joining us here tonight. Take good care, everybody. Bye-bye.
Thanks, everyone. Have a great night.